צהריים טובים לכולם. תודה רבה לכולם שהגיעו. אנחנו נתחיל בעזרת השם עכשיו את ההרצאה של פרופסור קרול. בתוכנית שלנו היום זה קודם כל כמובן ההרצאה של הפרופסור. הוא יציג את שיטת עיצוב שטף הדיבור, איך הגענו אליה, מה בעצם המתודות, מה הביסוס המדעי ואיך מיישמים אותו בשטח, וכמובן מהם התוצאות לאורך זמן. כרגע אני אזמין באמת את ישי כהן. ישי הוא בעצם המדריך האישי הראשון שהעסקנו חוץ מקלינאי התקשורת שלנו, לעזור בליווי של המטופלים שלנו. הוא עשה את הקורס ממש מהראשונים שפרופסור קרול בעצם ייסד בהדסה, והוא יציג את עצמו וניתן לו גם את הכבוד להזמין את הפרופסור לבמה. תודה רבה.
אני אזמין פרופסור קרול, באמת הזדמנות טובה להודות לך באופן אישי, ובאמת הקורס שהבאת פה לארץ, לי באופן אישי הוא שינה את החיים מהקצה אל הקצה, מחוסר אפשרות לדבר אחד מול השני. מיכל בוודאי זוכרת את התנועות לוואי שהיו, את הפחד שהיה, את החששות, והיום אני מדבר חופשי גם פה מול קהל, אבל בעיקר מול כיתה, מול תלמידים, ועושה חיל ברוך השם בהוראה. יישר כוח, אני מזמין אותך. אבל לבמה. תודה רבה.
Thank you very much for that lovely introduction. Words can't express how happy I am to be here. For those of you who don't understand my Anglit, you would probably be worse off trying to understand my Ivrit, so I better stick to Anglit. I'll try to throw in a few Hebrew words here and there just to make it sound like it's at home. First off, I'd like to thank you all and thank David and the Dr. Fluency Corporation for inviting me here today to give you a talk about the general principles of fluency shaping, a little bit about the history of how we came about to do this, and a little bit about my history in terms of how I got involved with Hadassah and Israel and so on. So I know that David is giving me about an hour and a half? Is that what you're saying? Including Q&A. Okay. So, and I'm sure there'll be lots of Q&A, because when you talk about stuttering, it's like talking about politics. All right? There's all different kinds of theories, all different kinds of definitions, different kinds of ways of treating stuttering. I'm going to try to walk you through a little bit about the history and how I came to do what I do today, and maybe confirm some of your beliefs or challenge some of yours, and I hope that you challenge me back, because it is still the jury, as they say in English, the jury is still out, and not everybody has all the answers, but we seem to be getting very close. And the most important thing to me, as a clinical tixoret, as a speech and language pathologist, is to see people moving on with their lives and being thankful and being grateful for the work that we've done. And I told David this little story. My two boys, by the way, my one son was born here, Hu Nolad Khan, when I was working at Hadassah. It's a very good place to work, because I was with a patient, and suddenly they called me, Ruvain, it's time. So I had to go back downstairs to the delivery room and watched my son being born. So very casual here. I really like that. But I worked in the right place. But my two sons, I now have two sons, and they used to ask me, Abba, are you rich? Do you have lots of kesef? And I used to say, no, not that much, but I'm very rich in other ways. And they said, what do you mean? If you don't have money, you're not rich. I said, no, I'm very rich in other ways, because I'm very grateful for the work that I did. I'm very rich with the memories of all these people that have written me 10 years, 20 years, 30 years later. Thank you so much for the help. Much like we heard just now. that's to me worth more than lots of money. Although money does help, of course. There's no question. But in that way, it really does help. So, David has asked me to present to you some of the sort of theory, some of the thinking behind our work that we do in Toronto and how it might associate with the specific work that Dr. Fluency is doing. And let me take you through some of these slides. So David has been kind enough to translate much of what I am going to say, but the problem is I don't really know if he translated exactly what I'm saying here on my English slides. So he could very well be putting words in my mouth, but if he does, if you notice that the Hebrew is not exactly what I'm saying, please let me know. Okay? Thank you.
יד ימין כדי להודיע לי לתרגם, יד שמאל כדי להודיע לדוקטור קרול שאנחנו מתחמנים אותו קצת. כן, בבקשה.
Okay, so I'm just pulling these up now, and I guess the title of my presentation is called Fluency Shaping, Application and Results. So we're going to briefly, this is a very ambitious agenda. איך אומרים ambitious?
So, agenda מאוד שאפתנית.
מאוד שאפתנית. It's a very שאפתנית agenda. So I'm not sure how much I can get through, but I'd like to talk to you about most of it. We're going to talk about the nature of stuttering. מה זה גמגום? What is it? How do people view it? Here, in North America, in Europe, etc. How do we define it? What's the characteristics of stuttering? What are some of the various treatments of stuttering that have been tried, that are currently being tried, and so on? And then going specifically into what is this fluency shaping? What's the theory behind it? What's it based on? What are the key ingredients of the process? How do we reshape the speech? I'm not going to go into any detail, obviously, in an hour and a half. I can't do that. There's specific training that maybe David, Chana can talk to you about. But just in general, how the speech is reshaped, how we transfer the speech from the clinic to the outside, and how do we maintain, that's the big challenge, how do we maintain the good speech that we can establish in the clinic? So we're going to talk a little bit about the process, a little bit about the challenges along the way, because it's not always just exactly the way the book says. Then we're going to talk about the mentality, the whole thinking about stuttering and about the person who stutters when he comes into therapy and how he's trying or not trying to manage his speech. What does he think about? What are the cognitive elements there, and how do we try to restructure those cognitive elements? And that's called cognitive restructuring. What do they think about? How do we try to change the thought process? And then, as I mentioned, what's our role in maintenance? What is the client's role? Or how do you call them here? Patients, clients, customers? Either one? Metupalim. How do the roles change from the clinician to the client? What kinds of practice do they have to do to maintain this speech even after טיפול? And then, of course, no talk is, at least in my mind, sufficient without treatment data. And so I'd like to present to you some of the data that we've been collecting over the years, walk you through some of the early studies, and then through some of the later ones. Because as clinicians living in the year 2012, or else 5,772, then we are held accountable for our work. And we've heard a lot about the term treatment efficacy, evidence-based practice. We have to do our practice based on what we find, both in the laboratory and outside, works. We can't just say, well, I do this because I think I should be doing it. Or the person told me that he's happier. Well, that's an important piece of data, but we have to be more methodical in terms of how we collect the data and what we are saying in terms of generalizing about therapies and treatments and so on. And finally, I'd like to show you some samples of videos. Is everybody understanding, or are some people struggling with the English? Is it okay so far? Yeah? What did I just say? Okay. No testing. Okay. So stuttering, not very easy to define. If you line up 25 clinae tikshoretz and ask them for a definition, they will give you 25 different definitions. So I just picked 3 definitions here. The first definition is from ASHA. You know ASHA, the American Speech Language Hearing Association. It says stuttering etc., just to try to impress you. An interruption in the flow of speaking characterized by atypical rate, rhythm, and repetitions in sounds, syllables, words, and phrases. This may be accompanied by excessive tension, struggle behavior, and secondary mannerisms. So that's really describing what we see in our clinics as stuttering, right? And then researchers, scientists, professors have, everybody has a new definition every Tuesday and Thursday, and they said, well, here's another definition. So we're not going to go through all the definitions, but interestingly enough, a couple of noted colleagues of mine have just come up with a rather interesting definition. And that's Nan Bernstein-Ratner, who's done a lot of work and done a lot of publishing in stuttering. And of course, you all might know Oliver Bloodstein. Bloodstein, Handbook on Stuttering. How many of you have that one? Handbook on Stuttering? Bloodstein? Anyway, he's a very well-known professor. I don't know if he's still alive even. I don't think so. But it says here, interestingly enough, for investigators who are anxious to define carefully what they mean by stuttering, the best definition that we appear to be able to offer is whatever is perceived as stuttering by an observer who has relatively good agreement with others, that's stuttering. So if you and your friend decide that somebody else is stuttering, that's the definition. Interestingly enough, in the year 2008, after all of these technical definitions, they came up, Bloodstein and Bernstein-Ratner came up with that one. Interesting. As far as the Stuttering Foundation of America is concerned, they have a nice definition here. Stuttering is a communication disorder in which the flow of speech is broken. Here we are again with the repetitions, prolongations, or abnormal stoppages or blocks of sounds and syllables. There may also be unusual facial and body movements associated with the effort to speak. So, as those of you are aware who have worked with people who stutter, depending on the degree of severity, mild, moderate, severe, you will see a number of these characteristics, either more or less. But so far, all of those definitions have been our professional definitions, what we observe when we see stuttering and how we describe it. From the client's perspective, from the person who stutters, and from the best of what we know as clinicians and what people tell us, it seems that they experience a momentary loss of control over the articulatory system, resulting in the behaviors commonly known as stuttering and as all of these secondary features. So they are talking, they know what they want to say, they know very well what they want to say, they know how to say it, there's nothing structurally wrong with the speech voice mechanism, but they can't get the words out. And they just feel at that particular moment, at that particular instance of disruption, a loss of control. So that, yeah.
כמו שהפרופסור אמר, הבן אדם יודע מה הוא רוצה, רגע נתון הוא לא מצליח להוציא את המילה. בדרך כלל אם הוא מתעקש, המילה בסופו של דבר יוצאת, אחרי כל התנועות הנלוות וכל הדברים האחרים שתיארנו, אבל בתכלס, מה שקורה אצל המטופל, אצל המגמגם, בפנים, זה חוויה של אובדן שליטה.
So specifically, when we're talking about the repetitions, the prolongations, here we have some specific types of fluency. And again, depending on who you read in the literature, there are lists of many, many specific form types of stuttering. These are the main ones. There can be audible or silent sound and syllable repetitions. There can be sound prolongations where they're stretching out the word. There can be dysrhythmic phonations. In the case of more severe stuttering, the child or the adult will try to get it out like that by changing the vocal pitch, by straining. Dysrhythmic phonation, that's what it's called. Severe blocks where there's nothing, you don't hear anything, the person is just frozen, there's a block. Or in between syllables, lots of choppiness, fragmentation. Not only in between, but within a syllable, there could be something like that. That's what's called intra-syllable fragmentation. And of course, there are many, many other form types that we see, and these can occur in isolation or in combination. And of course, in an attempt to avoid or else terminate an instance of disruption, the stuttering person will engage in a lot of what we call accessory behaviors or stuttering contingent behaviors. So to try to get out of the block, these can be disordered breathing, glottal fry, lip pursing, eye blinks, facial grimaces, head jerks, abnormal body movements, all trying to terminate the instance of disruption. Learned behaviors, which can become permanent, although most of the time they're temporary, because when one accessory feature stops working, another one is seen. Whether this is done consciously or subconsciously, hard to say. And of course, the big issue with stuttering is the avoidance behavior. People who stutter can avoid either at the sound or word level or else at the whole entire situational levels. So specific sounds and words, a lot of scanning, anticipating, sort of feeling ahead for what word or sound is going to be causing trouble, therefore resulting in substituting words, revising phrases, going around things, not continuing the communication, just not going to the particular party or to the event because for fear of people approaching and asking names and so on and so forth. So people who stutter exhibit to varying degrees avoidance behavior. So all of this is sort of the physical characteristics, the stuttering contingent behaviors, the avoidance behaviors. So it results in stuttering being a major life issue. Because for those people here in the audience who stutter and who have before treatment felt very restricted, you could probably identify with this. Stuttering quite often, not always, but very often, impacts on self-confidence, on self-concept, peer interactions, attitudes, emotions, etc. Quality of life. It's a quality of life issue. Because all of these maladaptive speech behaviors and avoidances are there, the person who stutters leads a life that's not quite complete in many cases. So what are some of the facts about stuttering? Everybody who comes to you as a clinician asks you, how many people stutter? What causes it? That's a big one, right? What do you answer? What causes stuttering? Isn't that a very famous question? Why do I stutter? Well, we don't exactly know, but there are some theories, and, I'm coming to you. I want some answers. What causes it? How many people? So what we do know is more than 68 million people in the world stutter, about 1% of the total population. So given locally, we could say if there's 7 million people ba'aretz, so how many would that be? 70,000 people. So there's still work to be done out there. Clinicians, David, Dr. Amir, there's lots of work to be done. We haven't finished yet. We know that approximately 5%, the prevalence rate in children is approximately 5%. Now, the research has shown that a great many, up to 70 to 80% of these children will outgrow stuttering without any טיפול. There are some people who say, don't wait. Let's just do the early intervention as early as possible. Some of you have been familiarized with the Lidcombe approach for preschoolers, for the little ones, or for the Palin approach with the little ones. Palin comes out of London, England. The whole idea there is early intervention is the way to go. Now, how many of these kids would have outgrown it anyway if you start working with them at the age of 2.5 or 3? Probably a good many, but it wouldn't hurt, I guess, to intervene early, as long as you're not wasting resources and making sure that you can, really treat those who really need it. Stuttering affects 4 times as many males than females. We know that. It has significant psychological effects, but the psychology doesn't cause the stuttering. We know that. There's no basis for the old adage that stuttering is caused by a psychological problem. There certainly are psychological offshoots to the stuttering. We just talked about those. But it's not the cause. Emotional trauma has not caused stuttering. I've sat in my office and mothers would tell me when I was pregnant, somebody broke a glass in the kitchen and I got scared, and that's probably why my child stutters. That's completely shtuyot, as we now know. That's not the reason. There's not one thing or one episode that has caused stuttering. Certainly emotional trauma, life events, negative emotions impact and sometimes can perpetuate stuttering and even, cause the stuttering to increase, but it's not the original, the etiology of it. Okay? Famous people who stutter, we all know that there are many famous people who stutter. Moshe Rabbeinu, right? He's pretty famous. King George VI, how many of you saw the movie The King's Speech? Wasn't that a great movie? It must have been interesting watching King George speaking Ivrit here. What about Winston Churchill, Marilyn Monroe, Carly Simon, a singer, North American singer, Bruce Willis, a North American actor, for those of you who know that. Stuttering pervades just about everybody, every occupation, every nationality, every language, and so on. Causes. Here's the main thing. Here's what you could tell your clients. What are the causes of stuttering? Well, there's more and more research. Even I've been associated with some of that research. We have new toys nowadays that we can do a lot of neuroimaging studies. And we see that there are certain neural substrates of stuttering. There are certain neural abnormalities that differentiate people who stutter from people who do not stutter. Once again, we're not quite sure what we're looking at there, whether we're looking at the chicken or the egg, because we may be just looking at the stuttering. Although many of the studies look at people who stutter when they're fluent and still see that the speech is processed somewhat differently from those who do not stutter. So we're looking more and more, we can say with more and more confidence today that there are neurophysiological underpinnings to stuttering. More and more work is being done in genetics, and we see that stuttering very often runs in families, but sometimes doesn't. But there's been a lot of work done on trying to identify specific genetic markers, so it could be a combination of these things. Stuttering has also been viewed from the point of view of developmental abnormalities being part of a syndrome of behaviors, and also in terms of environmental factors, not necessarily as causative factors, but as perpetuating factors, such as high-stress families, very demanding, etc., etc., etc. So we're probably, again, this is a wishy-washy answer because I haven't given you a cause, because in truth and in fact, nobody knows. We are getting closer to measuring it. We have technology now that can actually peer right into the deepest recesses of the brain of persons who stutter. We do see that there are not only functional differences, but there are now studies coming out with certain structural differences. Difference in terms of volume of gray matter and white matter. Without going into detail, there are these early studies that are coming out to imply that there could be some structural differences as well as functional differences as well. After all of this preamble, we're looking at a whole lot of things in stuttering. Looking at all kinds of things. We're looking at, of course, the disfluencies. We're looking at secondary behaviors. We're looking at family influences. We're looking at language or linguistic influences. What's happening in the person's environment. We're looking at his avoidance behaviors. We're looking at all those life issues like the self-esteem, the confidence, and so on. And we're also looking at fears. He's coming to us with lots of fears. So where do we start? The person who comes to us with stuttering has a lot on his plate. And in terms of therapy, we almost have a menu of where we can start working. So it's actually quite confusing. Even in terms of the research, if you read the research, you didn't translate that word, research. If you read the research, you will see in Bgmgum, you will see all different avenues and areas of research seemingly unrelated one to another. So there's research on brain imaging, as I've just talked about. There's research on reaction times of stutterers, how fast stutterers do things, how fast their reflexes are. You can read more psychological work on the temperament, what's the personality of stuttering like. What are the linguistic factors related to stuttering? Do people who stutter have language delays or language differences and so on? The genetics we've talked about, the environment we've talked about. So even in terms, and the motor learning, how fast or how automatic certain skills become as a result of experimental tasks, and how do they differ from people who do not stutter. So even in terms of the research, it's gone off in all different directions. So we have a lot of different things associated with stuttering, many different areas of research. So treatment. Naturally, we have just as many different forms of treatment for stuttering, depending on your politics, on your beliefs, on what you feel has worked for you, and so on. And if we take a look at the literature, we have various efforts at treating stuttering, ranging from counseling, just pure counseling, to desensitization therapy, to conditioning, straight conditioning therapy, giving somebody 5 shekels every time they're fluent, you know. That could cost you a lot of money, actually. To hypnosis has been tried. Drugs, pharmacology, I don't know here, but in the U.S. and in Canada, there has been some effort at researching various drugs, the most recent one being Pagaclone. Anybody ever hear of that one here? That's been used as an anti-anxiolytic, but now being tried with stuttering. And of course, there's, I'm sure you've heard of the Speech Easy device, a little hearing aid thing that you put in your ear and that will facilitate fluency. That's based on delayed auditory feedback or frequency-altered feedback. And that's being distributed, sold in North America. And then, of course, it leaves the last 2, which I'll tend to focus on because those are the 2 that seem to be right now the most current or the most popular, at least in North America and probably here as well. The stuttering modification therapy and the fluency shaping therapy. Of course, we're talking about fluency shaping this afternoon, but we also want to mention stuttering modification as well. So, there are 2 ways of approaching this in terms of our treatments and how we're going to attack this stuttering. We could try to aim at what we're going to see. Such as all the fears, the avoidances, the disfluencies, the family influences, and so on. And that is by the stuttering modification. Stuttering modification therapy, and probably the best known author of stuttering modification therapy, well, one of the first authors was Van Riper. How many of you have ever heard of Charles Van Riper? Yeah, I even have his book on my desk, and I have 2 books, The Treatment and the Nature of Stuttering. Very, very classic texts. There's even a video of Charles Van Riper doing therapy that you can get from the Stuttering Foundation of America. If you don't know that organization, it's a very good organization. It's not a therapy group. What would you call that? It's a charitable organization that really deals with stuttering and provides clinicians such as yourself with very low-cost materials that you can hand out to parents, or just Google them, Stuttering Foundation of America. You can actually buy a video of Charles Van Riper in action. He was an unbelievable therapist. The only trouble is nobody really knew how to do what he did. And that was the problem with some of the older therapists. We had these gurus, we had gods of speech therapy, but they were not that good at describing or disseminating or training others in terms of the techniques. But it would be very interesting for you to watch that DVD of Charles Van Riper in action. So I guess he was probably one of the forefathers of stuttering modification. More currently, there are people like Barry Guitar, who has done a lot of work with stuttering modification, Ed Contour, all of the students, generations of students of the people like Van Riper, Wendell Johnson, and Joe Sheehan, and a lot of these fellows. Stuttering modification deals more with the psychological aspects that we talked about. They're looking at avoidance and anxiety reduction, self-acceptance. They do teach certain speech modification techniques such as cancellations, preparatory sets, pullouts, etc. I'm not going to go into any of these details because you can read about them in Van Riper's texts even. Stuttering modification has been around for a long, long time. And essentially, stuttering modification teaches the person what to do when the stuttering occurs or when the stuttering is anticipated. If you feel it coming on, this is what to do. Do a pull-out, do a cancellation, or what have you. A lot of work on voluntary stuttering, desensitizing the person to stutter, a lot of go out there, and I had to do that as a student, I remember. That was one of my assignments in school. We all had to go out and pretend that we stuttered. How many of you had to do that? Oh, you still have to do that. It was a little scary, wasn't it? How many of you faked it? I sort of had that feeling that maybe I was just going to write my reflections but not really do it. And a lot of my classmates did that. It's not so easy, is it? But for a therapeutic technique, of course, the idea is to ask the person, go out there, you don't have to be afraid of your stuttering, just go out, hold the door of the bus open like this with both arms, and ask the, how do I get to Tachana Markazit? And do it on purpose. Make your stuttering fake, because that will just strengthen you. It will provide you with the courage to go out there and do it. And you know, in truth and in fact, that kind of therapy offered a lot of benefit to people, because they didn't think that they were capable of doing that before. Because the stuttering had them in a little shell. They were always closeted and afraid, and so on. The problem with it, though, was that even though they felt better about themselves and about things, they still had this thing in their mouth called stuttering. And so, I guess we created with stuttering modification a generation of well-adjusted people who stutter. And so, feeling better, but still having this motoric aberration called stuttering. The other issue with the stuttering modification was that even though it was proving to be of benefit for people, it was very difficult to collect data, very difficult to be sort of scientific about it, and to, you know, systematically go about measuring what kind of an effect this had. So that was the stuttering modification. And that focused on what we saw, all of the things that we saw. Or, the... Yep.
Because I don't have this for some reason in translation. מה שרק נסכם בקצרה, שהתיקון לגמגום, או עיצוב הגמגום, בעצם הגישה הזאת מתמקדה יותר בתופעות הנצפות, הדברים שאנחנו פגשנו בהם בסלייד הקודם, כל מגוון הדברים, ואז הגישה הייתה באופן ישיר גם להתמודד עם הגמגום, עם רגע הגמגום, על ידי כל מיני טכניקות של בוא נכין את עצמנו לקראת הגמגום כדי שנתפקד יותר טוב, אולי נעשה איזשהו ביטול מה שנקרא של הגמגום שהוא קורה, נעשה תיקון אחרי שגמגמנו, נגיד את זה שוב בצורה נורא, כל מיני שיטות של התמודדות עם הגמגום עצמו, עם תופעות הגמגום, וגם התמודדות עם הגישות והתחושות והאמוציות שקשורות לגמגום, על ידי הורדת הפחדים, על ידי ההתמודדות, כמו שתיאר הפרופסור, עם בעיות הגמגום בצורה חזיתית, על מנת לגלות שבעצם השד לא נורא כל כך, ואפשר לגמגם, ואפשר לתקשר, ואפשר לדבר. הבעיה העיקרית בכל הגישה הזאת, זה שבסופו של דבר היו באים לפרופסור ואומרים לו, היום אני מתמודד יותר טוב עם הגמגום, אני מרגיש איתו יותר בסדר, אבל אולי אתה יכול לעזור לי עם הדבר הקטן הזה שנשאר לי בפה, שנקרא גמגום, כי הוא עדיין מפריע, כן? והבעיה הנוספת, שלאורך כל השנים שאנשים מטפלים בשיטה הזאת, אין איסוף נתונים מבוקר, מסודר, מחקרים מקיפים לגבי השיטת טיפול הזאת.
Now, if he didn't say what I said, please let me know, but I'm sure he did. So that was, you know, the stuttering modification where we were looking at the whole, as they say in English, the ball of wax, the whole thing, and trying to address all of it, the fears, the anxieties, the avoidances, the all of the sensitivity to the stuttering and so on. Then along came, I'll tell you now a little story, because David always likes me to tell stories. He said, you have to tell them stories. And I said, okay, well, I will. Along came the behaviorists. People like B.F. Skinner and others started doing experimental work with animals, training them, like Pavlov, like a dog who, oh no, not the dog. What did Pavlov work with? He worked with the pigeon who was trained to peck. The dog was salivating, the pigeon was pecking. Yeah, he worked with a lot of different animals. But there was a lot of work going on experimentally in laboratories with behaviors. And we found, the experimental psychologists found, that behaviors can be treated as operants. In other words, they can be shaped. Behavior can be shaped. And you could train a dog to associate food with the ringing of a bell, or a bird to associate food with something else, and they'd start pecking. So the behaviorists began to start applying behavioral principles to things like stuttering. And they said, not only can we train dogs to do these things or birds, but we can also train people to speak more fluently just by applying some of the principles of operant conditioning and instrumental conditioning and so on. And so some of the early work in the 1960s and early 70s had people who stutter go through these behavioral therapies. Actually, some of them were negative therapies. So every time you stutter, you got a little zzz like that in your arm, or you got a token for being fluent and so on. And that created a great rift between two camps. Thankfully, that rift is not around that much anymore, although it might still be. I'm not so sure here ba'aretz. We could probably have some pretty good discussions about stuttering and about its nature and so on. But there were two very, very vehemently opposed camps of thought in terms of stuttering. Those who were the behaviorists, who said, if you can't measure something, you have no business dealing with it. So just count the disfluencies and just measure the stuttering, because you have no idea what a thought is, or what a feeling is, or what an emotion is. How can you be scientific about that? And so there were these two real camps of thought, the behaviorists and the more psychodynamically oriented people, and actually some of the people in stuttering modification. So after the behaviorists, after just the people doing these simple things like giving electric shock or giving tokens for being fluent, along came other people who said, well, maybe we can combine what we know about behavior and behaviorism with what we see happening in the mouths of people who stutter. And along came then the whole generation of fluency shapers. And those people said, what we can do is we can go right to the core of the apple. If you think about stuttering as an apple, the core are the repetitions, the prolongations, the blocks, and the rest, the meat of the tapuach. That's the fear, the anxiety, the this, the that, the other things. Because if you take away the stuttering, you will take away, first of all of the behaviors like that, because if he doesn't stutter, he doesn't have to do that, right? Plus, you'll take away a lot of the fear, a lot of the anxiety, and so on. So then came the fluency shapers, who applied certain principles of behaviorism and attached those to principles of motor learning, and just said, okay, this is the way we're going to do it. And then the story's not finished yet, because along came guys like me who tried to put both of those things together, and that's a big challenge, but we'll talk about that in a bit. So the fluency shapers started to focus about what's really going on in the mouth. And they focused, remember, on that momentary loss of control, resulting in the behaviors commonly known as stuttering. So they focused on the blocks, on the repetitions, the prolongations. So, okay, you're doing that. I know you feel badly about it. I know you're not feeling confident. I know you're anxious. I know you anticipate. But let's get right in there and let's see what we can do. So, they assumed in the early days what we have to do is rebuild or help you regain the control. And how do we do that? We do it by just giving your system a chance. Because I'm going to talk to you a little bit about the research in the laboratory lately, which points to the fact that people who stutter have speech mechanisms that are a little bit different from those who don't. So we have to give the system a little bit of an extra chance. We have to give the individual a little bit of an extra chance to become aware of what he's doing when he's talking. So we got to slow down the whole process. We have to look specifically at the breathing process, the phonatory process, and the articulatory process to first of all examine where the difficulties might lie. Then we have to bit by bit address all of those processes. First of all, by slowing down the whole process of speech, and then gradually through successive approximations, which is another term from behavioral psychology, build it up until we complete the whole rehabilitative process. So how we do that, or how the fluency shapers do it, is to establish fluency first within the clinic and reinforce that, first in a very exaggerated way, so that you're giving the person a chance to become aware of all of these fine-grained motor movements that speech involves. And then you gradually shape that into normal speech without directly talking at this point about the fears or about the anxieties or even about the secondary mannerisms. You don't address, that's very, very different from the days when we used to look at somebody who stuttered and say, okay, what's the worst thing about your stuttering? Well, the worst thing is I don't look at people when I stutter. Okay, so let's work on eye contact. Well, just look at me. Look at me when you talk. And the guy, freeze your eyes and look at me because that's the worst thing and we don't want you to look away. But really when you think about the response in terms of a behavioral model and a psychological model, those are stuttering contingent behaviors. Those are behaviors that are contingent on the stuttering. It's again the chicken and egg question. So first there is the stuttering, the repetitions, the prolongations, and then because you stutter, you try to do other things. Because you stutter, you look away. So it's like saying your feet hurt you. Okay, I've got very bad blisters, calluses on my feet. So you show it to the doctor, and the doctor scrapes off those calluses and does all the kinds of things, and then you put your shoe back on, and in 2 days you have it back again. That's because you're not really going to the core of the problem. The core of the problem is that your shoes are not fitting you properly, and they're causing you the blisters and the calluses. And what you're doing is you're trying to take the blisters off, but not changing the shoes. And so it's the same thing when you're working on the secondary behaviors. You're trying to take the blisters off, all of the sort of things that look bad, but you're not changing the shoes. You're not getting to the core of the apple. So there's no really direct work on the secondaries or on the avoidances until later on. And of course, the therapy is taken outside of the clinic. You got to get up off of there's a word in North America, it's called tuchus. I don't know if I'm sure you know that. You got to get up off of your tuchus out of the clinic into the real world to transfer the speech and to take the clients out there to address the generalization of skills. Why do we do all these things? Not just because we feel that it's a good idea, but it's based on science. It's based on laboratory findings. What do we find in the laboratory? Main things, without having you go back into the Journal of Speech, Language, and Hearing Research now, or some of the other journals, we can say that we do find in the research laboratory that people who stutter have difficulty coordinating articulatory movements and optimizing proprioceptive feedback. What does that mean? Well, they're difficult coordinating their movements. They also don't quite know exactly where the articulators are. They have difficulty with proprioception. We know already that there are neural differences. I've talked about that in how speech is planned and produced, and we can find that out through our studies using PET scans, using MEG studies, and so on and so forth. And you can read all about that in literature. And we've also found that people who stutter are a little different from those who do not stutter in their ability to efficiently and quickly learn new motor tasks and to make them more automatic. So we know that. They can learn, but they have a bit of a different learning trend when it comes to motor tasks. So we have to apply some of what we learn in the laboratory to our treatments. That's what's called evidence-based practice. We have to take the evidence that we get from the laboratory and we have to apply it to treatment. So the first example, we slow speech down. Van Riper slowed speech down 50 years ago. We know that prolonged speech is a very effective method. Why? Because we just, and I'll go back there, they have difficulty coordinating movements and optimizing proprioceptive feedback. They don't know where the mouth is. They don't know how to coordinate all of the breathing with the phonation, with the articulation. So what do? We slow the whole process down. We slow it down. And in terms of, fluency shaping, programs become more and more accurate. And this is where something like Dr. Fluency comes in. They couldn't be more accurate than Dr. Fluency because they've developed a computer program that will tell the person specifically how fast or how slow they're talking, that will measure specifically the duration of each and every syllable so that there is no questions asked. And the client and the clinician doesn't have to say, well, that was good or that wasn't good or that was pretty good or that was, a little better, a little worse. But the computer that they've developed will actually measure specifically the duration of each syllable to the 10th, I think, of a second, and then we'll check off, yes, you've matched criteria here. And therefore, you're slowing your system accurately at this point. And then you go on and make it faster and faster and faster. And again, why do we do this? To enhance their awareness and control of the specific motor movements of speech, and to provide a foundation for fluency. Because most people who stutter, when you slow the system enough, will be able to achieve a certain level of fluency. And that gives them a little bit more hope, a little bit more optimism to say, okay, I can do it at this level. Now what about level 2 and level 3 and so on? How else do we give people a chance to compensate for this sort of defective speech motor system? Well, we all know and we've heard about the term hatchala harka, right? Gentle onset, easy onset, soft start, easy start. I mean, we've known that technique for many, many, many years. And we know that people who stutter tend to start with 2 forceful aphonation, so that the vocal cords are in this locked position and apple, like that. And what we want them to do is to start the voice easy, to regain that control over their phonatory system, and rather than blocking on the word apple, apple, Argentina, actually, ordinary, to achieve a gentle onset, or a hatchala harka. Right?
Let's translate Argentina, Tapua.
Argentina. איך אומרים Argentina in Hebrew?
Go ahead.
Argentina. So what is that? That's the initial low amplitude vibration of the vocal cords. And how? And here, I must say, and I'm not hired here to sell Dr. Fluency, I can tell you that. I'm hired here because I wanted to come to Israel with my wife. I'm going to give a talk for David. It's my pleasure. But I would say, in my own mind, that the most relevant piece of the actual technical hardware of Dr. Fluency is the measurement of this gentle onset. Because a client who's working on this, you can't really see your larynx. You can't really see the vocal cords. You need to have some type of feedback to give you an idea of whether or not you're using those vocal cords properly. And so the Dr. Fluency program really is critical in giving that client specific and immediate feedback as to what they're doing with the phonatory system. So that's a gentle onset. Another example of what we do with fluency shaping. And here's another example. And remember the research. Always go back to the research. They have difficulty being aware of where they are, what they're doing with the various articulators. They have difficulty with proprioception or feeling and awareness and so on. So we also work on something called full articulatory movement. I know there's a lot of, not so much here, I don't know, maybe because of who we are as a people, we tend to talk a lot, and we also tend to move our mouths a lot. In Canada, there are many people who talk a lot, but they don't move their mouths very much. And they're sort of mumbling like this, you know. You can't really see a lot of movement at all. And they're really not feeling anything what they're saying. And if you put stuttering, bigmegom on top of that, it really stresses the system. And if you then add in the research, what we know about the difficulty coordinating and the lack of awareness of proprioception and so on, then you say, well, let's have the client move the mouth a little more, bit more exaggerated movement, which in most cases comes out to be just normal excursions of the articulators, so that you're giving the system again a chance to become more aware of where things are happening. And so there's a third example. So we slow speech down, we teach proper easy starts, we also teach greater articulatory movement. And those three things are just three examples. And again, as David said, if time permits, we're going to hear from Chana about some of the details about how we do these things. So here, this, in the fluency shaping that we do, is just a sort of a list of a lot of different targets that we teach clients, one after another. Each of these targets really is interconnected. And so we teach them a lot of things to think about, because they're already thinking about all these other things, these negative things. So what we're really trying to do is a little bit of rewiring. We're trying to focus their attention on the proper things to do for talking, not how to stop stuttering or how to avoid stuttering or how to anticipate stuttering, But let's not even talk about stuttering. Let's talk about talking. And let's talk about what it is you have to do talking. So, yes?
So, בעצם כל המשימות האלה, כשאנחנו קוראים להם הארטיסט והייצוג של הדיבור, הם רכיבים שמשתלבים אחד לשני, ובעצם יוצרים תהליך דיבור שבו המטופל, במקום לחשוב את כל המחשבות השליליות שלו על הגמגום ולהימנע מגמגום ולחשוש מגמגום ולהתמודד עם גמגום, הוא עכשיו מתמקד באיך אני מפעיל את המערכת בעזרת המשימות שמגדירים את הדיבור הנכון והשתף, איך אני בעצם עכשיו מפעיל את המערכת שלי בצורה הנכונה כדי להפעיל את הדיבור וכדי לשמור אצלי יש השליטה במערכת שאני מעבד אותה.
Okay. So, once we teach all of these targets that David has just talked about, and we teach them in isolation, and we teach them in very exaggerated ways, that's sort of the laboratory speech, then we gradually increase the speed to normal limits so that people can take that newly acquired speech skill out into the real world. And once again, going back to this computer program, the Dr. Fluency, at each specific rate level, it gives the client specific information of how fast or how slow the speech is and how accurate it is, until through this gradual process of shaping, of successive approximations, we get the client to where it is a natural sounding enough speech pattern to use outside and to transfer.
אז אחרי שרכשנו את כל היכולות, אנחנו יודעים להפיק דיבור בצורה נכונה, ולהפיק את כל המערכת בצורה נכונה, אנחנו מגבירים את הקצב כדי להגיע לקצב דיבור נורמלי, כמו שאמרנו, העדנו אותו, זה צופה הלמידה. המערכת המחשבת כל הזמן נותנת פידבק ובודדת בצורה מדויקת גם את הקצב וכמובן גם את הביצוע המדויק של כל המשימות שלמדנו אותו. ולמה אנחנו עושים את זה? על מנת לאפשר את העברת היכולות שרכשו לדיבור הטבעי, הנורמלי בחיי היום, תוך כדי וידוא שבאמת השפף הזה בא בעקבות העבודה הנכונה עם מערכת הדיבור כמו
So, if we can summarize what then the general principles of fluency shaping are, the first thing is that we want to be accurate. So we want to reduce response variability. We want to give the client clear and specific instructions of just exactly what we want him to do. So it's no longer valid to simply say, speak a little slower or take a better breath. Because again, if you ask 10 different people to speak a little slower or take a better breath, you will get 10 different responses. So what we've learned a long time ago, again from the behavioral literature and from the psychology and from the experimental psychologists, is that we have to reduce response variability. We have to make sure that our instructions to the clients and that the clients know exactly what to do within a certain window of a range. We also want to initially exaggerate speech responses so that the client, it's almost like putting the speech under a microscope and picking it apart and examining all the pieces. As I'm talking to you at this rate, even though people say I do talk rather slowly, but even at this rate, I can't really tell you everything that I'm doing with my articulators, my teeth, tongue, lips, palate, etc. So we have to use a lot of exaggeration in these procedures. Obviously, a lot of overlearning. Why overlearning? Because again, the laboratory tells us that people who stutter have more difficulty. The learning curve is a little different, and until they can automatize a new task, they require a little bit more time when it comes to motor speech processing. And then also, we have to intensify our practice. I think we've learned that clinically years ago. We've always been very good to our clients as speech pathologists. We're really good to them. To be honest, I think we're too good, you know. I can't see you on Tuesday at 3:30 because my daughter has ballet then. Can we see you Thursday at 10? No, because I have to take my son to Kadoregel. And so maybe we could, so speech is always being squeezed in someplace, and if they can't make an appointment, they won't come, and we're always sort of twisting ourselves around like a pretzel, trying to accommodate the client or the client's parent. I think that's no longer, and so we're just going to be frustrated then, because obviously the client or the client's family doesn't view speech therapy as a priority. We're not intensifying our treatment enough. We're not being sort of concrete enough to the parent to say, you know what, this is the program. It takes so many months. I'm going to be here at this specific time. I'm going to do my job. Your job is to get your child here at this particular time too. Yeah, but the buses are not running so good. It's far, it's this, it's that. A million and different excuses and kvetches. And then you'll say, okay, well maybe I'll see you Sunday morning at 6 o'clock. Is that good? Yeah, I think we can manage that. You know, when your dentist calls you, I don't know about here, but when he calls and you have an appointment, you go there. You know, if you really want that appointment. How come with us it's any different? And so not only do we have to intensify our treatment, we have to be a little bit more firm with our clients in terms of the importance of this, because it's hard enough to get people fluent, but if there's not that motivation or commitment, you're just wasting your time, as you know. So intensive practice to keep the momentum going and to make sure that there's enough practice so that the client is given a chance to automatize his speech. And then, of course, the big issue is taking it out of the clinic. What do you do after you've taught all these targilim, all these targets and so on? You've got to transfer it. And what is transfer? Transfer is not medicine. It's not going to happen automatically. It is the voluntary, this is my particular definition, or conscious application of learned or acquired behaviors outside of the clinic. But I can't, I'm scared, I'm not ready for this. I know my targets, I know how to do gentle onset, I know how to do, look at the computer, I can do it so nicely. Hey, very good, but go out there, make a telephone call, go to the store. I don't know, I'm a little bit nervous, but we've given you the tools. Go out there. You should be able to do it. To some people, going out there is scarier. They say, I'd rather jump out of an airplane and do a parachute jump than to go out there and talk. Or to come up here and talk. And I understand we're going to hear from some of David's clients, which is great. It's always nice to hear. Speech pathologists don't always like to talk in front of this microphone, in front of a group, right? That's true. It's funny, eh? It's very ironic that we're speech pathologists. We give refresher courses in Canada for our clients who have taken our therapy, and we invite them back for a little bit of tune-up, refresher, you know. And I remember one year I was planning the program with my staff, three of us, myself and two other people, Marnie and Lori. And both Marnie and Lori said, Bob, don't ask us to talk. We were planning the agenda. Who's going to do what? You know, I'll review this, you'll review. Oh, I don't mind going into the small groups, but I don't want to get up there and talk. I said, really? So I ended up doing the whole thing, of course, because they didn't want to. It's a big fear, number one. And if you have Bgimgum on top of that, it's even worse. So even sometimes when the person has learned all the skills, there's still those years and years of associations that we have to work with. And that's where this whole issue of cognitive restructuring comes in. That's the alteration of attitudes, feelings, and beliefs and emotions associated with the act of talking. This is the hard part. We try to replace the irrational thought with more accurate and beneficial ones through counseling, through self-realization, and so on. This is where we sort of bring the two worlds, the stuttering modification, the fluency shaping, together. So even though the fluency shaping is the core, you're giving people the tools. You still have to facilitate the process. You have to support them through the process. People are not machines. This is a machine. It's a great machine. It's called a MacBook Air. I just got it before I came here. It's very light. I would recommend it to anybody. But this is a machine. You turn it on, it does what you do. I wake up, my machine doesn't always work. Sometimes I'm in a bad mood, sometimes I'm in a good mood, sometimes my back hurts me, sometimes I can hardly get out of bed. I'm human, right? And people with fears are human. So we have to work with that. So when do we introduce this transfer? Let's say we're working with a client for, on a weekly basis for a few weeks, months, and so on. When do we start saying, okay, let's go outside, you've learned the skills, let's go outside? First of all, I would say, like a good politician, not too early and not too late. How's that for an answer? Well, not too early, because sometimes your clients get very excited. Oh, I slowed my speech down. I can talk perfectly. Or sometimes a mother is in the clinic with the child. Say, oh, that's great. Well, thank you very much, Mr. Clinician. We can go out there and, kill the world now. Do it. No, that's not the case. It's too early. You haven't gone through all the steps. Remember the research again. People who stutter have difficulty sort of automatizing these things and need a little extra time. So not too early. Don't get them so excited. It's not bad to show in therapy that you can, that there is light at the end of the tunnel, but please be realistic with your expectations. On the other hand, don't delay transfer until, it's too late. By saying, oh, I'm really afraid of the phone. I know you want me to use the phone today, but can we do it next week? 'Cause I don't really feel like doing that. Please? Okay, we'll do it now. I feel so sorry for you. We'll do it next week. And next week comes and it's the same story again. Okay, well, let's just practice the phone. Let's put our hand on the phone. At least talk to each other while our hand is on the phone. Don't delay it too long. Because if you delay it like that, you're feeding the client the notion that it's not the speech that's causing the stuttering, but it's the telephone that's causing the stuttering. And the whole idea behind fluency shaping is you're reconstructing speech so that you should be able to use it on a full-time basis, whether you're talking to your little child, whether you're talking to a professor, whether you're talking to anybody on the phone. It's not the situation that causes stuttering, it's your attendance to these targets, so on. So you don't want to wait too late in the program. So for transfer, the way we do it and teach our clients is that there's three steps to transfer. First of all, there's that mental rehearsal. Pick two targets. What's two very important ones for you? And think about those and visualize yourself doing those targets even before you go up to somebody to ask them a question. Get yourself in the proper mental set to say, I'm going to do this. I'm ready now with my full breath, my gentle onset, whatever I'm doing. Just pick two of them and make sure that you're ready. Then, as you open your mouth and you're talking while applying the target. So you're going with a monitored form of fluency here. And finally, the third step, Let's evaluate it objectively, not subjectively. Oh, that was great. I feel like, wow, I'm ready to do anything now. Or, oh, that was awful. I feel like jumping off that nice new bridge that they just built here. It was terrible. No, not subjectively like that, because there's always another trial that you can do next time. So being objective. So what are some of the problems that we encounter during transfer? Is that, first of all, the client is operating by the old medical model. I did all my targelim, I did all my stuff with Dr. Fluency, I did all my prolonged speech, my stretching of the syllables, and I go out there and it doesn't work. The targets don't work. What do you mean the targets don't work? Well, I just started talking and they didn't work. Oh, that was after the fact. You opened your mouth, you started talking, you didn't apply your techniques because you didn't have those 3 steps, that mental rehearsal, the preparation, the talking carefully with the targets, and then the evaluation, right? You didn't have that. That's true. It was sort of like I took my pill and it didn't work. But that's the old medical model. So the targelim, the exercises, that's not to be thought of as a pill. That's to be thought of as just the foundation behaviors. Then you're continuing the therapy outside. Or sometimes the client is just overcome with negative emotion, or not being viewed as an opportunity to practice. And these are all situations that challenge us as clinicians and that we have to address. So this is just an indication of how difficult a job we're asking our clients to do. Nobody said this is easy. This is not easy. Here is what we're asking the clients to do. Oh yes, thanks. First of all, again this way. Oh, yes. Sometimes it takes them a little time to wake up. First of all, the client has to think about what they're going to say. They have to formulate a message. And that occurs in this part of the brain. Then, we've taught them all of these targets, these targelim. They have to plan to use those fluency skills by using their mental rehearsal, as we just talked about. So they have to use that part of the brain. So they're formulating a message. They're also at the same time thinking about the 2 targets, the full breath, the gentle onset. And then they have to talk using the targets. So already that's a pretty impressive demand on the brain. And if they also, in addition, are worried about certain things, oh, this is an important person, I might have to talk to him, and I'm nervous, and he might not have patience, he might not listen to me, or I might stutter, or oh, I hope I don't have to say my name, because I know if he asks me my name, I'm going to really blow it. So all of this is called negative self-talk, and that activates certain arousal systems of the brain. And even in terms of our imaging studies, we see areas such as here, the anterior cingulate. This is a person who stutters before therapy, or this is a group of people who stutter before therapy using PET scans, and we see activation of the anterior cingulate. Anterior cingulate is an area that's known to be related to pre-planning, anticipation, anxiety, arousal, and so on. And so there it is. Afterwards, we don't see that kind. Or, I mean, for the person who doesn't stutter, we don't see that activation with the same experimental task, just reading a list of words. So, remember the first slide, all that we're asking, if you overlay it with this, then we call that the garbage center. For lack of a better word, this is the garbage center. We say to the people, if the garbage center is overactive, you're not going to be able to use your targets because you're overcome with negative emotion. You're activating all those, arousal systems in your brain, and your brain can't deal with all of these competing thoughts. So here's this poor guy, and he's got some negative self-talk here. I hope the teacher doesn't call on me. Maybe I'll just pretend I don't know the answer. I hope they don't ask me to introduce myself. Here comes a word that starts with D. Let me pick another one. It could be D, it could be Bet, it could be Aleph, whatever it is. I know they're going to laugh at me if I don't start. I don't want to answer the phone. The phone's ringing. I'm going to go the other way. I hope Ima answers it. Right? That's the stuttering mentality. All of these maladaptive thoughts. I'm going to be judged. I have to be perfect. There's certain expectations of me, and I'm going to be looked at as not very competent. I'm going to lose power in this conversational situation if I stutter. I'm going to lose control. The people won't accept me. They won't approve of me. I'm just overcome with fear. All of that. Doesn't matter how many targets they know. If this is still happening, we haven't completed the job. So, again, we talk about altering attitudes, feelings, and belief systems and replacing faulty or irrational thought. That's not an easy one to do, but that's where we really are challenged as clinicians. That's where we have to be sensitive and experienced and well-trained and understanding what people are made of to do that. We have to change that negative thinking to more positive self-talk, such as instead of saying, I'm going to block on my name, I'm going to remember to use my full articulatory movement and my gentle onset. That's going to be very helpful. Or here's another challenge. Here's a lady sitting in the front row. I can go up to her and ask her for the time. I don't even want to know the time, but it's a good chance for me to practice my speech. That's a very different attitude from, geez, I hope nobody comes and talks to me here. All right? So, all of these little sayings, replacing the old thoughts with newer, more productive thoughts. And we do a lot of work on that in the clinic and little exercises and so on. And I guess this is also very important because the fluency that we're after in this transfer is not just a lucky, unrehearsed, unmonitored fluency, but it still is a fairly monitored fluency. It's a careful fluency. A lot of people sort of attack fluency shaping because it produces a sort of an artificial sounding voice. A lot of clients even tell me, they could be 45, 50 years of age, and they're talking fluently, and they say, you know what? It doesn't sound like me. It's not me. And I'll say, well, what sounded like you for the last 40 years? Stuttering. We took it away. Any change, even a change for the better, you have to get used to it. It's like putting on a new shirt or like putting on a new jacket that you haven't been used to. It doesn't sound like me. I have to get used to it. I just got these new glasses. My wife says they look very nice. To me, I look like a grasshopper in these things, But I'll get used to them. It seems to be more in vogue now to wear these cool, thick-rimmed glasses. I came from a rimless glasses, right? Now I'm wearing these. Every time I look in the mirror, I still sort of react, ooh, who is that? But eventually I'll get used to it. Same thing with a change. Any change, when people undergo change, there are reactions. Even if that change is a positive change. Plus, on top of that, initially, and you'll see on some of the video samples, right after treatment, speech does sound somewhat more controlled. But remember, they need the time to automatize. They need the time to make it more natural. And you'll see that happening as well, as long as we don't run out of time. That is probably, when I first started in this business of fluency shaping, I learned it from Dr. Ronald Webster, and I didn't have time to tell you a little bit about that history, but I realized very soon after I started is that without follow-up and maintenance and continued adherence to the program principles, people are going to regress, and they're going to go right back to where they begin. So all of our work for the last 20 years has been designed to strengthen our follow-up and maintenance program. So even after טיפול is sort of finished, after the establishment and transfer phase, you need to have a gradual fading out of your interactions with the client, so that until the client feels that, yes, I can do it more or less on my own, I can problem solve, I can give myself exercises, and I know what to work on, I know where my weak areas still might be, and you've taught me everything you can right now. That's when maintenance is finished. So for instance, in our clinic, and I think having spoken to David here, he uses the same format. After therapy, clients are seen once a week for about a month, then once every 2 weeks for another 2 months, and then once a month for the duration of that calendar year. And when you've been in the business as long as I have, just because that year is finished, it doesn't mean that clients can come back to see you for have refreshers or tune-ups or what have you.
I'll just summarize that. מה שהפרופסור מספר זה כשהוא למד את שיטת פסוק של הדיבור מרונלד ובסטר, שפיתח בעצם ועשה את מה שפרופסור קרול מכנה הפקקג'ינג של החבילה הזאת, של הפסוק של הדיבור, כי כמו שמענו, כל הפרינציפים האלה הם בסך הכל דברים שידועים פה ושם ומוכרים, אבל לקחת את זה ולהפוך את זה למסכת טיפולית ולמהלך טיפולי שלם, זה באמת היה החידוש של פרופסור ובסטר. וכשהוא סיים ללמוד אצלו, הוא הבין מהר מאוד, פרופסור קרול, שאם לא תהיה תוכנית של שימור השתן לאורך זמן, אז התוצאות כמעט תמיד יאבדו. זאת אומרת, לא תמיד תהיה חזרה לגמגום כמו פעם, אבל בהחלט תהיה ירידה בשטף וחזרה אחורה ורגרסיה, ולכן באמת פותח המודל הזה שבו יש גם מפגשים שבתדירות פוחתת והולכת עם המטפל, יש גם תוכנית תרגול מאוד מאוד ברורה שבין 20 דקות לחצי שעה ביום על מנת לשמר ולטפח ולחזק את היכולות ולדדה את המשך ההתקדמות וחס וחלילה לא לסגת אחורה.
Can you go to So how long do we do this maintenance? David just told you about the schedule. But what we're really after as clinicians, when is it finished? It's when speech is no longer an issue for that client. You know, there may be still some gimgum there. Let's not kid ourselves. But when speech is not an issue, when he can communicate to anybody, anytime, any place. When we see in that client, regarding speech, observed confidence and comfort level for communication. And obviously, when the disfluencies, when the gimgum is at a minimum, very little, if any, right? That's when more or less the maintenance is done. When it's no longer an issue, it's not part of that person's set of issues anymore. So, what does all of this tell us? How do we summarize it? Well, there's 3 critical phases of fluency shaping. There's the establishment phase where we train with the Dr. Fluency, all of the speech rate, the respiratory, the voice, the articulation. Then there's the transfer and the cognitive restructuring where we help clients to apply what we've learned. And then there's the maintenance where we consolidate the treatment gains. I just want to show you a couple of videos now of a client before and after, so you can see the very sort of controlled speech immediately after treatment, and then of a client a few months down the road, what he sounds like before, after, and then a few months, and another one. So can we do the first one?
Chemical girls better.
Okay.
And yeah, they're older, so never really run away or anything.
Okay. And I know you mentioned you did have therapy in the past. Can you tell me a little bit about what you learned and the results?
When I took therapy, it was only for like an hour, and I think it was only like a few times a week, so it wasn't really like hard at it or anything. I was really young, so my head was kind of like up in the air about everything. What I remember learning was a lot of pronunciation and trying to
Okay, now that was Lucas. He took an intensive program with us. And let's see him after about 60 hours.
Okay, so why don't you start and tell me your name and the date today.
My name is Lucas Sandretta, and it is January 27th, 2012,
Right.
I think.
You're right. Have you made any improvements in your speech fluency?
I really think I have. This program has really helped me, I think. Just being able to control what I say and how I say it, and even make me.
Okay, now obviously there's a change in the fluency, but there's also some artificialities. He's using that monitored kind of fluency that is so often apparent. But that's sort of what we want to see right at the very end of therapy, before maintenance begins. And during maintenance, the challenge is to help that client naturalize the speech. So here's another double literature that you'll see.
There are certain situations that make it a lot harder, such as having an interview like we're having right now, things like that, when I know I'm sort of being particularly watched, or in the cases when I have to talk and the only form of communication is through my speech, and I have to be very clear and concise, such as talking over the phone. I find that a little very difficult.
What specifically happens to your speech when you stutter?
It's really strange, like as I'm coming up to a word, I know I won't be able to say it.
And you can look at me, you don't have to look right at the camera. So could you start by telling me your name and the date today?
I'm Richard Holmes, and it is October 21st,
And the year?
2011.
And have you made any improvements in your speech fluency since you started this program?
Yeah, I think I'm now doing things in an easier way of talking, and sort of have equaled out my bad habits, and hopefully have replaced them with good ones.
Good. So can you describe some of the different transfers?
So the targets I'll be...
This is 6 months after that date.
It is very useful to do first thing in the morning, because it sort of sets what I'll be doing the rest of the day. And I've found a few times if I do it more near the afternoon, I've already generated worse habits, and it's harder to correct it. And first thing in the morning, I've found that very successful. As for structured practice, every week at Toastmasters I'll be doing a speech, along with the work I've been doing with the police. So
you can see then a preaching first, the second, and the third, which is typical of what we do. But without that maintenance program, we wouldn't be able. Similarly, speaking with David, he does the weekly approaches, so he works on naturalization right along as we go along. I want to show you one more, which is a very interesting case. This was a police officer who suffered post-traumatic stress disorder.
John Corcoran, Corcoran, the 5th of October 2009.
Okay. And how did you hear about this program?
I was referred by a speech therapist in Barrie.
Okay. And why are you seeking help regarding your speech at this point in your life?
so I can go back to work.
Start off by asking you some questions. Would you like to begin?
It's the 23rd of October, 2009.
Sounds great.
Thank you.
Have you made any improvements in your speech fluency since you started this program?
Yes, I speak more effectively, and I now do not gulp or snort like I was when I came into the program.
Okay.
I feel that there's been a huge improvement.
Start, I'm just going to ask you a couple that helped you when using your newly learned fluency skills in situations outside of the clinic.
I think that for speech, I just rely on what I learned in the 3-week course.
Okay.
I may have used some techniques that I learned for the treatment for PTSD to enhance my breathing and to relax myself.
Okay. And what are the specific strategies you use from the program that help you most?
So those are just some examples of not just the pre and the post, but also what happens in terms of follow-up and how the inflectional patterns and the other features of speech tend to naturalize over time. Of course, these are clients who are very dedicated to the maintenance process, and that's really why we're seeing those kinds of results. So, I'm going to hand it over now to David, who's got another part of the program.
אנחנו תכף נקרא לפרופסור שיחזור לבמה להציג קצת מהתוצאות מחקר שנערכו לאורך זמן. התוכנית שלו כבר פעילה מאז 1976. לפני כן, מה שכן, יש לי פה, חשבנו שניתן קצת לבוגרים שלנו לדבר. אתם כולכם מוזמנים להישאר גם אחר כך לכנס בוגרים שמתחיל בשעה 5 וקצת לצפות ולראות ככה איך זה מתנהל. כעיקרון אני אקרא רגע עכשיו לנדב שקצת ממהר ללכת, שקצת יספר לכם על הסיפור שלו.
שלום שלום. אז קודם כל אני רוצה להודות לדיוויד על כל הטיפול והתוכנה וכל הדברים, ושמח להכיר גם את פרופסור קרול. אז אני אציג את עצמי קודם. קוראים לי יוסף נדב לוי, אני בן 20 וחצי, עוד מעט 21, לומד בישיבה פה בירושלים, בהר המור. את התוכנה התחלתי כשהייתי בן 12 ומשהו, היום אני, כמו שאמרתי, בן 20 ומשהו. אני הייתי בגיל 3 התחלתי לגמגם. ההורים המבועלים שלי הגיעו לכל המומחים, לכל הפרופסורים פה בארץ. לדוקטור קרול הם לא הגיעו, אבל הם עשו את כל הטיפולים, את כל המומחים, עד שבאיזשהו שלב אמא שלי ראתה את העבודה של התוכנה של דוקטור פלואנסי בעיתון. והיה אחרי תהליך של איזה 10 שנים בערך, שעברתי המון טיפולים, אני זוכר פגישות והמון תהליך מאוד רציני של כל טיפול אפשרי בעצם. ההורים שלי מאוד נבהלו מזה, בטח בהתחלה, כשזה פתאום מופיע בגיל 3. זהו, ואז אחרי שהגעתי לטיפול הזה של דוקטור פלואנסי, התחלתי לעבור את הטיפול עם הצוות המסור, שהיה מגיע לפחות פעם בשבוע, לפעמים אפילו יותר לבית שלי, ודייוויד יכול להעיד עד כמה עצלן הייתי ועד כמה הרמתי עליהם קשיים, וזה, ברוך השם, היום, כמו שאתם רואים, בזכות התוכנה ובזכות... אז ככה אני מדבר. אולי נסיים בברכה שכל המגמגמים הצליחו למצוא מרפא וארוחה לכל המחלות וכל
שלום לכולם, אני אספר קצת על עצמי לפני שאני רציתי לשתף אתכם באיזה סיפור שהיה לי. אני התחלתי את הקורס לפני 2 שנתיים. בהתחלה נכנסתי לעניין מאוד מאוד חזק. והצלחתי להגיע לשתף מאוד מאוד חזק. ואחרי שנה, כמובן, ככל שאתה נמצא יותר בעניין, אתה פתאום מזניח פה, מזניח שמה. והגעתי לרמה, כאילו הייתי מאוכזב מעצמי, נקרא לזה ככה. ואז כאילו בזכות דיבי, בזכות עוד כמה, פשוט חזרתי לזה שוב פעם, הוא לא הרפא, שלח שליחים וזה, שאין כזה דבר, הוא לא מוותר. במיוחד לאור המצב שהגעתי, כאילו מצב מאוד טוב, אז חבל לרדת מהרף הזה. וברוך השם, עכשיו לאחרונה חזרתי לעניין עוד פעם, כמו שאתם שומעים. וזהו, עכשיו היה סיפור שרציתי לשתף אתכם, כבר סיפרתי את זה בקבוצות, שהייתי ישר אחרי שסיימתי, הרי בקורס יש כמה דברים, יש את התוכנה שאתה לומד אותה, ואחרי זה שאתה מיישם אותה. אז אחרי שסיימתי את השלב שלה ללמוד את התוכנה, אז נסעתי עם דוד שלי לרבי דוד אבו חצירה, מי שמכיר אותו. רב מקובל בנעריה הוא מקבל. ונכנסתי אליו, ואז הייתי עוד בשידוכים, ודוד שלי ככה מקורב אליו, אז הוא אמר לו שהרב יברך אותו, יש לו בעיה של גמגום, וזה מפריע לו בשידוכים וזה, שהרב יברך אותו. אז ככה, להפתעתי ככה, הוא אומר לי, אתה למדת את התוכנה, למדת את השיטה. כאילו, לעזאזל, מי אמר לך? למדת את השיטה, עכשיו אתה יודע, וזה רק תלוי בך. והוא אמר לי יותר, הוא אמר לי, כאילו, אתה יודע מה השיטה, הרי לנשום ולדבר ולהתחיל רך. כאילו, ואז בכלל ככה, נתקו לי המילים מהפה, כאילו, אוקיי, טוב, להתראות, רק אל תגיד לי יותר מדי דברים על עצמי, כאילו, אני לא... זהו, והוא אמר, עכשיו זה רק תלוי בך, אם תתאמן תדע, אם לא תתאמן לא תדע. ואחרי זה גם שיצאתי, אז דוד שלי אומר לו ככה, הרב בכל אופן, שהרב יברך אותו משהו, אמר, אין לי מה לעשות. זה תלוי בו, משהו יעשה, יצליח, אם לא יעשה לא יצליח, וכמו שאתם רואים, כאילו, אז שלא עשיתי, כאילו אחרי שנה מהזה, אני פשוט הזנחתי, הגעתי למצב לא טוב, עכשיו שאתם שומעים אותי, כן, היה לי תירוץ טוב אמנם, אבל זה גם תירוץ, זה עדיין תירוץ. וכמו שאתם שומעים היום, זה אחרי עבודה של 2-3 שבועות, אני התחלתי ככה לתפוס את עצמי, ואני מקווה שבעזרת השם אני אמשיך הלאה. וגם רציתי בהזדמנות זאת רק תודונת קטנה למדריכים ולצוות.
ישראל נמצא פה עם אשתו, למי שככה חוששת עוד לברכה של רבי דוד. הינדי, אם את רוצה לעלות.
שלום לכולם, קוראים לי הינדי ובר, אני בת קרוב ל-20. אני רוצה לספר לכם באיזה מקום אני הייתי, ובאיזה מקום אני היום נמצאת בזכות הקורס. אני הייתי עד גיל 16. הייתי מאוד מאוד היה לי קשה, לא הייתי מסוגלת לגשת לבן אדם ברחוב כדי לשאול משהו. לא יכלתי ללכת לשכנה לבקש. לא העזתי להתקשר לחברה כדי לשאול אותה משהו, והייתי אומרת לאחותי, כמעט מכריחה אותה שהיא תתקשר, כי הייתי נתקעת הלו, זה היה קריטי. וגם בכיתה לא העזתי להצביע, להקריא דברים, אפילו דברים שהייתי בטוחה שזה טוב, אני יודעת. וזה לא שלא היה לי ביטחון עצמי, היה לי הרבה, אבל רק הגמגום זה מה שחסם אותי. ככה הייתי עד גיל 16. זה היה מאוד מתסכל, מאוד מאוד מדכא. ואז בעצם גיליתי את השיטה המדהימה הזאת, ואני מרגישה שבזכותה ממש נולדתי מחדש. קיבלתי את כל הכלים, וזה כלים מדהימים. מה שמדהים פה בעצם, שאחרי שאתה יוצא מהקורס, אחרי השנה, אתה לוקח איתך את הכלים, ואתה יכול ליישם ולתרגל כל הזמן. אני הייתי עושה בדרך לעבודה שיחות יישום עם הפלאפון שלי, כאילו, לא דיברתי עם מישהו, אבל ככה באתי לעבודה ודיברתי ככה 5 שעות טוב, הרגשתי טוב עם המשימות, הכל זרם, הכל היה שוטף, היה כיף לדבר ככה. מה שבעצם גיליתי שהרבה יותר קל לדבר עם המשימות מאשר בלי, כי אז אתה מבזבז הרבה יותר אנרגיות. וזהו, אני מאמינה שכל מגמגם שיעשה את הקורס הזה יוכל להצליח אם הוא ישקיע באמת, והוא יעשה את כל המאמצים כדי להגיע לזה. זהו, אני בעצם, אני חושבת שהשיא שהגעתי לזה, זה היה כשעברתי איזה קורס, אז בחלוקת התעודות היה משוב, וישבו שם כמה חבר'ה של 20-30 מורות ומנהלות של רווחה וכל מיני, גם מנהל, וכל אחת הייתה צריכה להגיד מה שהיא לקחה מהקורס, ושם באמת הצלחתי להגיד את זה, את כל מה שרציתי, בנאום משימתי. זה היה גם אחרי כמה דקות שתגלתי ככה בשקט, כמו שלמדנו בקורס. זה מבחינתי זו הייתה חוויה מדהימה, שככה בזכות זה קיבלתי עוד מוטיבציה ועוד מרץ להמשיך לדבר מהמשימות. בהצלחה.
הינדי הזכירה את הביטחון עצמי שהיה לה למרות בעיית השטף. אני זוכר כשנפגשתי איתה פעם ראשונה, פגשתי בחורה מאוד מאוד דעתנית, שממש התערבה לי בכל השיחה, למרות הגמגום הקשה והתנועות הנלוות, ואיך שנכנסתי הציגה לי קלסר שהיא אספה במשך השנים בצורה מתודית, כל מה שאי פעם נכתב או נרמז משהו לגבי גמגום, היא הייתה אוספת את זה ושמה בניילוניות, והיא הראתה לי את הקלסר שהיא אספה. אנחנו נבקש עכשיו באמת מהפרופסור שיעלה ויציג את התוצאות של המחקרים.
Well, those speeches were most inspiring, obviously, and those were great students, and it's interesting. We were talking before the break about naturalness and so on. Obviously, these students have worked very hard and gone from that very controlled, monitored fluency to a very natural, fluent-sounding speech now, which is great, and I give all three of you all the credit, which is fantastic, and it's a lot better than looking at videotapes that were taken in Canada and here seeing the people. So how do we measure success? Well, obviously that's the best measure of success, just looking at people. But from a research point of view, from publication point of view, professional presentations, what are our criteria for success? Well, there are two sets of criteria. The behavioral criteria, that's the hard fluency data, and then there's the communication criteria. Let's talk about the behavioral criteria. What we want to see in our therapy programs is significant positive change in speech output. We want to see that speech output transfer or generalize across many speaking situations, and we want it to be sustained through our maintenance programs. That's what we want to see behaviorally.
והשני זה הקשורי. בקטגוריה הזאת של ההתנהגות אנחנו רוצים לראות שינוי תגובי ברור ביכולת הפקת הדיבור, שהרבה פחות דיבור, הרבה יותר שטף דיבור. אנחנו גם חייבים לבדוק שהיכולות האלה הן באמת מופקות ומצטרפות לרוחב, זאת אומרת, בכל מצבי הדיבור השונים. לא רק מה שאנחנו רואים בפרקטיקה, ושלישית גם כדי ללמוד באמת הצלחה, צריך לראות שזה משהו שמחוזק לאורך זמן, כמו למשל השבעה חודשים, או כמו שדף סיפר מה 10 שנים, מילי סיפר על 3 שנים או 4, זה באמת האובייקטיבי של השטף הפיזי שאנחנו רוצים ללמד וללמוד אותו.
And the second way of measuring treatment results is how the people are communicating, what they're doing with this fluency that we've given them or that they've been able to establish and maintain. So as I mentioned before, the ability to talk to anybody, anytime, about any topic, anywhere, is really the final result of what we're after. The fluency is the means to the end. To be able to communicate effectively and efficiently, and to be able to do so with little more than just a little bit of anxiety or negative emotion, no more so than anybody else would have coming up here talking to a microphone in front of an audience. So this represents the second set of criteria that we as clinicians have to measure, and there have been a lot of researchers out there doing qualitative research as well as quantitative research, trying to develop instruments that will get to both these behavioral criteria as well as the communication criteria.
השטף הדיבור הוא לא המטרה, אלא האמצעים למטרה. כמובן שהמטרה זה יכולת התקשורתית של הבן אדם, כן? לוודא שהוא מסוגל לדבר עם כל אחד, בכל מקום, בכל זמן, להגיד לו מה שהוא רוצה ובאיזה מילים שהוא רוצה. גם לוודא שהתקשורת עצמה היא אפקטיבית והיא יעילה, לא בעצם שצריך לחכות שהיא לא יוצרת אי-נוחות לשומע ולמדבר, וגם לראות שכל הדברים האלה שהזכרנו, המטופל או הבן אדם שגלגל, שהוא עושה אותם ביום עם מעט מאוד יחס שלילי או פחדים או צדדים רגשיים אמוציונליים, שיהיה כמה שיותר מינימלי. ישנם כלים שפותחו לאורך השנים כדי למדוד את הדברים האלה באופן מדעי, ואנחנו תכף הפרופסור יציג.
So, having said all that, that's what we're after. So, here's a summary. What did we find over the years? Did we achieve our goals? What kinds of results do we get with these kinds of programs? Now, you've seen some live results, you've seen some videos and so on, but let's talk a little bit more in greater numbers. So here's some very early treatment efficacy studies that we ran, that were presented at ASHA back in the 80s, actually. We took, this was a retrospective study. We took 100 randomly selected people who've been through the program, the original fluency shaping strategy, just pre and post, and we could see by the yellow bars that there was a pretty significant shift in fluency counts from pre to post. And
אפשר לראות את הגרפים הירוקים של לפני הטיפול הופכים לגרפים הצהובים שאחרי הטיפול.
This was an early 2-year follow-up study. Obviously, when we started doing our work on maintenance, we wanted to see, we took 14 randomly selected subjects. These were subjects that we also used for some of our PET scan studies. And we followed them. Now, some of them did the maintenance program, some of them didn't. So this is additive data, this is group data, and so we have to be a little bit careful here. But we could see that from pre to post there's a pretty dramatic shift, and then 2 years following there's a slight regression, and when looking more closely at that regression line, we saw that of those 14 subjects, the ones that were regressing more were those that didn't really show up for those maintenance sessions that I described before. So there is some regression following an intensive period of treatment. We can head off the regression by very actively encouraging the patients to come back for those maintenance sessions. And then we also ask them not just fluency scores, but as I said, we need measures of communication, how well they're doing with their speech. We developed our own situation checklist, and there's about 160 items on it, and the higher the score, the better you're doing. And so you see the change, the significant change from pre to post. They go quite high, and then at the follow-up stage, there's a slight regression again in terms of how they feel they're doing in an everyday situation with the speech that they've learned. More recent studies, we have 85 subjects here that we are reporting on. There's significance at the 0001 level from pre to post, both in reading and in conversation. And you see the light blue is conversation, the dark blue is reading, and that's the pre in terms of the 85 subjects grouped, and the post down here. We're also using an attitude scale now called the OASIS. That's Scott Yaris in Pittsburgh has developed that measurement scale. It's the, just trying to think of what the acronym stands for. Does anybody know? OASIS. Experience of adult stuttering. But the O, I don't know exactly what it stands for. But it's a checklist of situations, not a checklist, it's a rating scale where the client has to rate on a 1 to 5 scale. Observations of the adult stuttering, experience of stuttering. Observations of adults, situations and experiences of stuttering. The adults have to measure on a have to rate on a 5-point scale how well they think they're doing, and the more or how poorly they think they're doing in certain situations. And in this case, the higher the score, the more negative the feelings are. So they have gone, these group of 88 subjects, from around 3.5 down 1 full point to about 2.5 in the post, which is within normal limits. And this is the PSI, the Perceptions of Stuttering Inventory, which is a measure developed by Wolf way back in 1967. Again, the more the score, the more involved the person is with his stuttering. 10 or less indicates more of a normal person's reactions. So we see in pre going from almost 30 to post going to about 13 or 14, which is a very significant decrease there. And this is based on quite a number of subjects, 88. Our current maintenance data, we're working hard. Remember that curve that we sort of showed, that little V curve? We're working hard at trying to flatten it off. Here's another maintenance study for 13 subjects, and we're finding that our maintenance is getting better because we are encouraging the people more and more to come to the therapy. We've even thought about paying them to do that. But short of doing that, we just are sharing all of this data with them, and we're saying, look, if you want to continue working on your speech and maintaining it, this is what you're going to have to do. If you don't, here's the data. Here are the results. Very, very important, not just to share data with you, the colleagues, but with clients as well. We share everything. We share our neuroimaging studies. We share these data that we collect with our clients so that they will understand just what the job is as far as sustaining the gains that they make in treatment. So who can benefit from therapy? Who can benefit from this kind of therapy? Anyone suffering from disfluency can benefit. That doesn't mean everybody will. Anybody can. Obviously, there are extenuating circumstances. If somebody comes with specific disabilities, with developmental delay, with physiological limitations, etc., 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 naturally, the therapy, the instructions have to be modified, and so on. Stuttering, cluttering, the fellow with the neurogenic stuttering, the adult late onset, has benefited. Regardless of the severity, there's a loss of control. If a person expresses this loss of control, the therapy approach, the fluency shaping, teaches the person, takes the mystery out of stuttering and teaches that person, stuttering can be explained. And by explaining it, you're taking the mystery out of it and therefore rebuilding the control. The results obviously will depend on the client's time, the commitment, the effort, the investment. We talked about that before. Okay, so in summary, I've been given the cane here, they've taken me off. What is fluency shaping? Fluency shaping really is one of the only methods for treating stuttering that actually collects data and that has been proven to produce long-lasting fluency. It's a very labor-intensive and grueling rehabilitative process. That's for sure. It's not easy. It requires a very specialized and focused program or clinic. Fluency shaping has to be comprehensive in that it addresses both the problem as well as the behavior. You need both the technology, such as Dr. Fluency, as well as the psychology. The other thing is the therapist has to be well-versed, well-qualified, well-trained to deal with this. It's not just, what do I do now? At page 2 it says do that. Obviously there's a specialized training that has to come along with this. Otherwise you're not going to get the results that you'd be looking for. And long-term success is obviously dependent on a structured maintenance program. I always tell my clients when they say, does it work? I say, you get out of it what you put into it. In that case, fluency shaping is probably the same as many other therapies. If your heart is into it, you get out of it what you put into it. You do the work, you get the results. The take-home messages, final messages for you to take home. Number one, in Israel, as well as in Canada, as well as in Europe, anywhere else in the world, there are very few of us that are treating stuttering. I've been treating stuttering myself for a long, long time, but everywhere I go, there's just a handful of people, just like there are here, who are interested in the area. And yet, stuttering represents 1% of the population. We already said there are 70,000 people here in Israel who stutter. So what people who stutter, PWSs is a nice word for people who stutter. What they need are more qualified and trained professionals. We also want to make sure that we don't do anything that's not based on science. Make sure that the practice, whatever practice you do, is evidence-based. Not just, well, makes me feel good, or I think this is a good idea. If you think something is a good idea, test it out. Perform, go to your local specialist in the university or whatever, ask to do some collaborative work, and design a study where you can test out certain experiments, certain therapies. But don't do anything if it's not based on science or evidence. And if you want to do fluency shaping, then make sure, as you do with any other program, don't call the program fluency shaping if your friend told you about easy onsets or something like that, and you're claiming that you're doing fluency shaping. That's a huge problem we have in Canada. In Canada, we have structured therapy courses, postgraduate courses that allow people to attain a certain degree of competence using certain treatments. But then there are always others who will say, can I borrow your notes, and can I look at page 15, and I think my client might do this, which is fine, but don't claim you're doing a specific program. Make sure that you've got the comprehensive training, the knowledge, the skill required, and then you will reap the benefit of what you can do. It's very rewarding to see people go through from severe stuttering to real good fluency, but in order to do that, you really have to have the proper training. So I thank you very much for inviting me today, and hope that good luck to you.
אנחנו רק נבקש מיוחנן ככה שהגיע מרחוק, שיבוא ככה לתת איזה...
שלום לכולם, קוראים לי יוחנן. אני אשים לב על התחלה רכה ועל לימון זר. גם הדוקטור כאן דיבר בקשר לכלים, בקשר למשימות. רציתי רק להסביר שמה שאנחנו הרווחנו כאן בקורס, כל אחד ואחד, זה שיש לנו את כל הכלים ואת כל האמצעים לומר מה שאנחנו רוצים להגיד. השאלה היא כמה אנחנו משתמשים באותם הכלים שאנחנו קיבלנו בקורס. ורציתי קצת אולי לומר, עליי קצת להציג את עצמי. אני החודש הזה מסיים 4 שנים בקורס. אני בן 37, נשוי, אני אב ל7 ילדים. רציתי לומר, בעבר אולי הייתי נמנע מלעשות כל מיני דברים, אם זה קשור בערך באספת הורים שהיו בעבר, אז הייתי די נמנע, הייתי שולח בעיקר את אשתי, אבל היום ב4 שנים האחרונות אני כבר עושה את זה לבד, אני עונה לכל מיני שיחות טלפונים, אני גם הולך לכל מיני אספות הורים שיש לי, ורציתי לדבר על עוד נושא, שמה שדיברו כאן על הנושא של השימור של כל הדיבור הזה, אז מה שיש לנו כאן זה המפגשים השבועיים, שאנחנו נפגשים פעם בשבוע, כל אחד עומד ואומר כמה מילים, ולפני שניגשים אומרים על מה שמים לב ועל איזה 2 משימות, וככה אחרי כל דיבור של כל אחד יש הסבר מקיף, איך היה נשמע, מה היה נשמע, מה צריך לשפר ומה לא, שזה הדבר שיכול לשמר את כל מה שעשו בקורס בצורה הטובה ביותר. ולסיום אני ממש רוצה להודות גם לדיוויד הריס שעוזר לי וגם תומך בי, ולכל הצוות שלו, הצוות המסור, גם בעבר וגם בהווה, ואני מאחל לכולם המשך ערב מענה וכל טוב. תודה רבה על ההקשבה.
אני מדבר על לפני 23 שנה התחלתי את הקורס, אי שם באייר תשמ"ט, 89, בעת היותי בן 19, ומאז ועד היום אני לא אגיד שאני מתרגל כל יום היום, אבל בהחלט לאורך תקופה ארוכה תרגלתי הרבה מאוד, ושוב בליוויה גם העזרה וגם המילים והעידוד של מיכל לכל אורך הדרך והפניות שלה בטלפון משעות הערב. היום כאדם נשוי אני לא מבין איך היה לה את הזמן לזה, אבל כנראה שזה היה חשוב לה. היום אני עובד בחינוך, עובד בהוראה, אני מורה בבית ספר בקיבוץ שדה אליהו, חבר צוות ניהול של בית הספר. אני מזכיר את זה פה כי זה לא רק לעמוד מול כיתה, זה גם לעמוד מול כל מיני פורומים ואנשים מכובדים כאלה ואחרים, שמי שמבין, אני מקווה שאתם קצת מבינים בגמגום, זה נושא לא קל, לעמוד מול קהל, לעמוד מול אנשים מכובדים, זה מלחיץ, זה קשה. ברוך השם, בעזרתו של פרופסור קרול, אני זוכה ומצליח, עושה את זה בצורה טובה. היום אני גר במושב שדמות מחולה בבקעת הירדן, עוסק בחינוך בהוראה. זהו.
שלום לכולם, אתם בטח משערים, שומעים אותי? אתם בטח משערים שאני הייתי מגמגם, אז באמת הייתי מגמגם עד, זה התחיל לי בגיל, אני לא בדיוק זוכר, אבל בגיל די מוקדם. בטח רובכם או כולכם אפילו יודעים את הקושי שיש בגמגום, זה מאוד מלחיץ, כל פעם שיש איזה משהו בכיתה, כל פעם שאני נמצא בבית הכנסת, אז אתה לחוץ, אולי יקראו לך לתורה וזה, זה מאוד מלחיץ. אבל עכשיו, אחרי שעשיתי את התוכנה, ברוך השם, זה מאוד עזר לי, אני מרגיש הרבה יותר ביטחון עצמי לעמוד לפני ציבור. כמו שהגעתי לפה, אני הייתי בטוח שאני אדבר לפני איזה 300 איש, בסוף אני רואה שזה קצת פחות, אבל זה ודאי נותן את הביטחון העצמי. בישיבה שלנו יש שיעור שיש מישהו קבוע שמוסר אותו. היה איזה שבוע שהוא לא יכל למסור את זה, אז אמרתי לו בוא אני אמסור במקומך. כל יום הגעתי, מסרתי את השיעור, ברוך השם זה מאוד עזר לי, ותודה רבה לדיוויד ולכל נריה גם כן הגיע, הוא היה מדריך שלי, תודה רבה לכולם ותודה.
אז כמו שאמרנו, אנחנו מפנים עכשיו את